Incentive spirometers sit by nearly every postoperative hospital bed, yet pulmonary complications remain a persistent daily clinical reality. Standard clinical practice often centers on the movement of the plastic piston rather than the specific biomechanics of the breath. Instructing a patient simply to make the indicator go up frequently results in a rapid, forceful inhalation, fails to reach the lower lungs. On the left, a sharp, rapid breath spikes the indicator before it instantly drops. On the right, a slow, controlled effort allows the indicator to rise smoothly and hold steady. This device provides visual feedback to the patient, serving as a gauge for the effort rather than an active delivery system for air. Clinical efficacy depends upon the precise execution of a sustained maximal inspiration, a maneuver requiring a specific trans-respiratory pressure gradient to expand the alveoli. During normal spontaneous breathing, chest wall muscles contract and pull outwards. This causes a drop in the intrapleural pressure transmitted to the alveoli, pulling alveolar pressure below baseline airway pressure. This creates a trans-respiratory pressure gradients, driving airflow down the trachea. This chart graphs resting lung volumes. Normal tidal breathing is a gentle wave resting at the functional residual capacity or FRC baseline. A sustained maximal inspiration expands the lungs from the FRC up to the absolute inspiratory capacity limit, followed by a deliberate breath hold. Generating a greater sustained transpulmonary pressure gradient is the only physical way to maximize the full potential for alveolar expansion. Without that expansion, patients face pulmonary atelectasis, a state where healthy inflated alveoli slowly deflate and shrivel into a collapsed non-functional state. This collapse is highly probable following upper abdominal or thoracic surgery and in patients with severe COPD or diaphragmatic dysfunction. Surgical trauma alters these biomechanics, postoperative pain, and diaphragmatic dysfunction physically stop the chest wall from expanding during inhalation. When expansion is restricted, the transpulmonary pressure gradient drops, functional residual capacity decreases, and delicate basal airways are forced to close. Healthy individuals prevent this basal closure through spontaneous sighs or yawns, creating massive pressure gradients to keep the lower airways open. Because surgery inhibits this natural deep breathing, the sustained maximal inspiration maneuver acts as a prescribed sigh to force these collapsed basal airways back open. To guide this maneuver, we use two categories of hardware: volume oriented piston style devices and flow oriented multi chamber ball models. Despite providing different visual feedback, both devices require the exact same biomechanical effort from the patient. Successful administration follows a specific loop: a slow inspiration to set a target, a brief breath hold, a normal exhalation, and a period of rest. The most critical constraint of this maneuver is velocity. The inspiration must be slow to ensure the air reaches the intended areas. High velocity air follows the path of least resistance. A rapid breath floods the already open upper airways, bypassing collapsed basal alveoli entirely. But a slow inspiration decreases turbulence, allowing air to distribute evenly, navigating deep into the lower branches to reinflate collapsed basal segment. Once the target volume is reached, the brief breath hold provides the necessary time for alveolar recruitment to occur. Reaching a visual target on the plastic casing is ineffective if the underlying breath was not slow and sustained enough to distribute the air. Patient selection is essential, as incentive spirometry is contraindicated for several populations. Patients who cannot cognitively understand the instructions, refuse to cooperate, or lack the physical capacity to take a deep breath are disqualified from the intervention. Inappropriate or unmonitored use introduces physiological hazards, beginning with the hyperventilation. Repeated rapid breathing on the spirometer depletes carbon dioxide levels, which can trigger respiratory alkalosis. Excessive use can lead to pulmonary barotrauma, exacerbation of bronchospasm, and severe patient fatigue. Postoperative analgesia is a prerequisite for success. Inadequate pain controls makes it physically impossible for a patient to perform a deep, effective inspiration. Utilizing an incentive spirometer with an inappropriate or under-medicated patient fails to provide therapy and may cause active physiological harm. The clinician must set the individualized target volumes, manage post-operative pain, and actively verify the patient's biomechanical technique. Clinical monitoring must include the frequency of use, actual breath hold time, vital sign stability, and changes in the breath sounds. While the standard baseline is 5 to 10 maneuvers per hour, the regime must be individualized based on the patient's real-time clinical status and fatigue. The clinician drives the therapy through coaching and monitoring. The plastic device is simply the tool that displays the result. Incentive spirometry is a monitored physiological event. To be effective, the inspiratory effort must be slow, deep, and sustained.